Bismillahirrahmanirrahim. Welcome back everyone. This is Dr. Waqas from Pathology Department. Today we will continue with the second lecture of restrictive pulmonary diseases. In the last lecture we learned about the different types of restrictive pulmonary diseases, pneumoconiosis, an example of cold-workers pneumoconiosis and silicosis in the restrictive lung diseases. So today we will continue with the asbestos-related lung diseases. So what is asbestos? Asbestos is a fibrous hydrated magnesium silicate. It is derived from the Greek word meaning unquenchable or inextinguishable. It has long thin fibers with a length to width ratio of 3:1. Its properties include sound absorption, average tensile strength, affordability and resistance to fire, heat and electricity. That is why it is used in insulation industries and also as soundproofing. There are two commercial forms of asbestos, the serpentine form and the amphiboles. Serpentine forms include chrysotile, which are wavy and long. Amphiboles include coccidolite, needle shaped with many long fibers, amosite, which is a thicker one, anthophyllite, actinolite, and tremolite. These are all the examples of the commercial forms of asbestos. There are two types of exposure. Number one is the primary exposure, which occurs in miners and millers. The secondary exposures occur people working in manufacturing plants using asbestos in the production of tiles, friction materials, tires, and insulation materials. Direct exposure occurs people working in sheet metal work, plumbing, pipe fitting, insulation, railroad, and utility work, or school or building custodians. Indirect exposure occurs through household contact with the materials having asbestos. The bystander exposures, it means people working near the asbestos workers or asbestos related factory. These are the non-malignant pleural manifestations in which include pleural plaques, diffuse pleural thickening, rounded atelectasis, and acute pleural effusion. So looking at the morphological structures related to the asbestosis or asbestos related diseases, the number one is asbestos bodies. Asbestos fibers accumulate in the interstitium of the lung and are coated by iron and amosite in a beaded club fashion referred to as ferruginous or the asbestos bodies. As you can see in this histological slide, this is known as the ferruginous or the asbestos bodies. Both of these are the examples, and you can see that these are in the form of beads and arranged. So let's look at the first manifestation of asbestos related diseases. This is the pleural plaques, which is the most common manifestation. In its pathogenesis, the asbestos fibers are transported by the subpleural lymphatics to the pleural space, where they cause inflammation and with time fibrosis. The mesothelial cells also internalize asbestos fibers via an integrin receptor that recognizes vitamin acting, and pleural mesothelial cells can also synthesize collagens, which are type 1, 3, and 4, elastin, laminin, and fibronectin, which are deposited in these pleural plaques. Macroscopically, they appear as grey-white regions of pleural thickening, often thickest at the margin, giving rise to the holy leaf appearance. As you can see, this is an example of holy leaf appearance, and these are the leaves which are thickened at the margin as compared to the center. Histologically, you can see extensive collagen fibrils arranged in a basket weave pattern and a thin covering of mesothelial cells. The parietal pleura is uniformly involved with minimal thickening of the visceral pleura. Looking at the clinical features, like other restrictive lung diseases, is also asymptomatic in the early stages or the early exposure, and you can see incidental findings in routine chest X-ray, and these are usually bilateral. Radiological features will show lesions in the lateral and posterior mid-lung zones in the rolled holy leaf pattern as described in the previous slide, especially if they are calcified. CT increases plaque detection, so it is more sensitive as compared to the X-ray. There is no specific treatment for this. The only thing you can do is medical surveillance or decrease exposure to the asbestos. So these are two chest X-rays of a person having asbestos related disease or the pleural plaques. As you can see, there is fibrosis on both side of the lungs, and this is a pleural plaque. As you can see, it is hollow leaf shaped. So this is a gross picture of pleural plaque. You can appreciate the thick borders as compared to the center, which is thin. So what is asbestosis? Asbestosis is an interstitial pneumonitis and fibrosis caused by exposure to asbestos fibers. It is characterized by discrete areas of fibrosis in the walls of respiratory bronchioles. Peribronchiolar cellular reaction that may narrow and obstruct the airway lumen. So it is another example of pneumoconiosis. Looking at the pathogenesis, asbestos fibers are deposited at the respiratory bronchioles and alveoli. From there, they migrate into the interstitium and cause alveolar macrophages to accumulate. This causes alveolar macrophage alveolitis. Following the alveolitis, most of the fibers are usually cleared, but if the clearance is incomplete, fibers can ensue. These fibers induce apoptosis or programmed cell death, and some of the asbestos fibers are coated to form asbestos bodies, which makes them less toxic. But most of the fibers remain uncoated and they are still toxic to the body, especially the chrysotile split longitudinally and generates additional fibers that can multiply the asbestos effect even after the exposure has ceased. Asbestos fibers then stimulate the macrophages to produce a variety of important cytokines and growth factors which are involved in the inflammatory response and ultimately lead to fibrosis. Among the cytokine, interleukin 8 recruits neutrophils to the sites, platelet derived growth factor, insulin like growth factor 1, interleukin 1 beta, and tumor necrosis factor alpha stimulate tissue fibrosis by fibroblast proliferation, chemotaxis, and collagen biosynthesis. Bronchoalveolar lavage and CT scanning and 67 gallium scanning have demonstrated that the inflammatory events occur well before the onset of the clinical disease. So the person does not show any clinical symptom, but the inflammatory events are already going on according to the exposure a person has with asbestos. Looking at the clinical features, the patient will have difficulty in breathing on exertion, and this is the earliest symptom. Bibasilar rales are a distinctive feature. Restrictive impairment with a reduction in lung volume, especially the forced vital capacity and the total lung capacity, this will be decreased. The lung diffusing capacity will also be decreased, and it will lead to arterial hypoxemia or decreased oxygen levels in the blood. Looking at the morphology of asbestos related diseases, as you can see in these slides, asbestos is marked by diffuse fibrosis, which is distinguishable from the diffuse interstitial fibrosis resulting from other causes, except the presence of multiple asbestos bodies, which you can appreciate here, which are also known as the ferruginous bodies. These are the only thing which will be specific to the asbestos related diseases. These appear as golden brown fusiform or beaded rods with a translucent center and consist of asbestos fibers coated with an iron containing proteinaceous material. So this is another example of asbestosis. Both of these are the asbestos bodies or the ferruginous bodies which are stained with Prussian blue stain. As you can see here, these are stained blue. There is no established treatment for this disorder just like the other pneumoconiosis, but due to the risk of lung cancer and mesothelioma, medical surveillance is done with CT scans, especially for people who smoke greater than 30 pack years and age is greater than 55 years on the annual. So our next and last disorder is pulmonary sarcoidosis, which is also included in the group of restricted lung diseases. It is a very important disorder. So what is sarcoidosis? Sarcoidosis is a multisystem non-caseous granulomatous disorder of unknown etiology characterized by depression of cutaneous layer type hypersensitivity and heightened Th1 immune response in affected organs. So it is a type of autoimmune disorder. It commonly affects young adults, but the ratio of females is greater than males. It presents most frequently with bilateral hilar lymphadenopathy, pulmonary infiltration, and skin or eye lesions. The exact cause of sarcoidosis is still unknown, so it is an idiopathic disease, but some theories suggest exposure to pine pollen or beryllium, infection with mycobacterium, viruses, and fungi, and protoplast or L form of tuberculous bacillus may be a cause of sarcoidosis. But all these causes are not well established or proven, so the exact cause is still unknown. Let's look at the morphology. The pathological hallmark is the presence of non-caseating epithelioid cell granuloma. Non-caseating epithelioid cell granuloma, this is a very important pathological hallmark and it differentiates sarcoidosis from other disorders. Active sarcoidosis has nodular collections of large closely packed pale staining histiocytes, epithelioid cells within giant cells. Necrosis does not occur. Electron microscopy showed that epithelioid cells tend to be central and macrophages are peripheral. As the lesion ages, reticulin fibers between the epithelioid cells ramify and convert to collagen. The cytoplasm of the giant cells have inclusion bodies, which are the Schwann bodies and the asteroid bodies. Looking at the Schwann bodies, these are round or oval and vary in size from that of a leukocyte to about 100 micrometer in diameter. The larger of these bodies, the conchoid bodies, seem to be formed of basophilic concentric lamellae that appear to contain calcium and iron. Double refractile crystalline inclusion bodies are 1 to 20 micrometer in diameter and may take up stains from calcium and iron. The third one are the asteroid bodies, which consist of central mass 2.3 to 3 micrometer in diameter with radiating straight or centered spinous projections, the whole being 5 to 25 micrometer in diameter. Due to this spinous projection, these are known as the asteroid bodies. So these are the two histological slides showing the asteroid bodies. This is an asteroid body, and you can appreciate all the spinous projections coming out of the body, and these are all basophilic giant cells. So this is an example of Schwann body, this one indicated with the arrow. What are the sites involving the sarcoidosis? It is characterized by formation of non-caseating granulomas in lungs, which is the most common site, lymph nodes, skin, liver and heart, CNS, bone marrow. So it affects a variety of organs throughout the body. Lungs. Lungs are usually the common and the first site which are involved in sarcoidosis, and it begins with simple alveolitis involving small bronchi and small blood vessels. The alveolitis either clears up spontaneously without any treatment, or it leads to granuloma and ultimately fibrosis or extensive disease. Clinical features. Around 50% of the patients, as usual, are asymptomatic. The common symptoms are dry cough, dyspnea. Chest pain is very rare, but it can also occur in pleural effusion. Wheezing secondary to the endobronchial disease, extensive compression by lymphadenopathy or bronchial distortion secondary to fibrosis can also occur. Productive cough occurs only due to traction bronchiectasis. Hemoptysis, bronchiectasis, or aspergilloma can also be seen in the clinical features of sarcoidosis. So this is a chest X-ray of a patient with pulmonary sarcoidosis, and you can clearly appreciate the bilateral hilar lymphadenopathy. These arrows indicates the hilar lymph nodes which are enlarged in sarcoidosis, and this is commonly the most important symptom a patient presents with. So these are all the organs and the systems involved in sarcoidosis. In the nervous system, it causes meningitis and encephalitis. It can also cause lacrimal gland granuloma. In the heart, it causes pericarditis and arrhythmias. In spleen, it causes splenomegaly. Lymph nodes are also involved, having granulomas. In the joints, it causes arthritis. In the skin, you can see erythema nodosum and subcutaneous nodules. In the liver, you can see granulomatous hepatitis, hilar and mediastinal lymph node granulomas, and all of these will show non-caseating granuloma in the histopathology, which is the hallmark of the sarcoidosis. Let's look at the pathogenesis of sarcoidosis. It involves the development of a cell-mediated response to an unidentified antigen, as the cause is still unknown. So the CD4 T cells, which are also known as helper cells, they interact with that unknown antigen, and this interaction releases cytokines causing formation of non-caseating granulomas. The important cytokines involved in this pathogenesis are the interleukin 2, which causes T cell expansion, interferon gamma, which activates the macrophages, interleukin 8, and the tumor necrosis factor. So this is a picture of inflammatory phase in the lung. From the it starts from here and it ends here. You can see the increase in progressive inflammation and ultimately fibrosis. So what are the associations of sarcoidosis? So the first association is erythema nodosum, which are painful purplish nodules usually over the shins, and shins are basically the anterior surface of the legs. These regress spontaneously, but they leave bruised appearance after they resolve. Lofgren syndrome, sarcoidosis associated with erythema nodosum, arthritis, and hilar lymphadenopathy is known as Lofgren syndrome. Hertford syndrome, sarcoidosis associated with fever, facial nerve palsy, parotid enlargement, and uveitis. So these are the other intrathoracic manifestations: pleural involvement in 5 to 10 cases, aspergilloma, bronchiectasis leading to productive cough, necrotizing sarcoid angiitis, superior vena cava syndrome due to the compression symptom, mediastinal lymph node calcification, mediastinal fibrosis, and vanishing lung syndrome or giant bulla. Lab findings. So the lab will show elevated serum angiotensin converting enzyme, hypercalcemia and hypercalciuria, increased ESR, increased immunoglobulin level, lymphopenia, and delayed liver function test. The bronchoalveolar lavage will show increased lymphocytes in the active disease, CD4 to CD4 ratio of greater than 2.5, which is increased, CD3 to CD4 ratio of less than 0.31. So these are the staging of sarcoidosis on the basis of chest radiographs. In the stage 0, there are no abnormalities. In the stage 1, there will only be lymphadenopathy. This occurs in 50% of the cases. As you can see here, this is bilateral lymphadenopathy. In the stage 2, there will be lymphadenopathy plus pulmonary infiltration, which is seen in 25 to 30% of the cases. This is the pulmonary infiltration. In the stage 3, there is pulmonary infiltration. This picture represents the stage 3, and the last stage is massive fibrosis, which occurs in the 5% of the diseases. So what is the management of sarcoidosis? In the acute disease, the only treatment is bed rest and the use of non-steroidal anti-inflammatory drugs, which decreases the inflammation and also resolve the acute episodes. So this type of treatment is supportive. But there are some indications for corticosteroids as it is an autoimmune disorder. So we will give prednisolone 20 to 40 milligram per day. These indications are parenchymal lung disease, uveitis, hypercalcemia, neurological involvement, and the cardiac involvement. So this ends our topic on the restricted lung diseases. Thank you.